the mesiolingual, and there will be a groove, a lingual groove between them, as shown by the blue line. Okay. If we look at the tooth from a proximal aspect, and in this case, it's the mesial aspect, you see the crown is inclined, the buccal crown or cusps are inclined toward the lingual here. This is lingual, and this is buccal. And again, same reason as with the premolar teeth, it just facilitates their interaction with the maxillary teeth in the opposing arch. They are wider at the cervical third of the tooth, and there's this prominent buccal cervical ridge here shown by the orange star. Let me see if I can find my cursor here. Here we go. Okay, so there's your buccal cervical ridge. I'll circle it. You should see this crown really bulges out. Oop, bulges out here. Again, here's the mesial marginal ridge, and that's typical of, as we've seen in other posterior teeth. And the buccal cusps are more rounded and the lingual cusps are sharper. So again, this is different from what we've seen before in posterior teeth. Usually the lingual cusps have been more rounded and shorter. In the mandibular molars, it's the opposite. Okay. This is the mesial aspect of the root here. It's a very wide tooth root, buccolingually. It's huge, okay? And it is likely to have this longitudinal depression I spoke about before on its mesial aspect. And on this image, it is actually backwards. That would be actually in this area of this tooth. And it's possible that the gum has kind of grown over, extended over, but this is where it would be on this tooth root. You see, also there's a distal depression on that mesial root also. So this is the distal of the mesial root. Okay, but the most characteristic one is this mesial depression on the mesial root. Okay.
I'm sorry, Miss Simmons, what does that say?
The top one says mesial of mesial root. Sorry,
okay.
Just can't write with a mouse.
No, I know. It's okay. I can't. Thank you.
Sure. Okay. Any other questions about this one? Okay, distal aspect, the crown is shorter in height than the mesial. So, you know, we see more of the occlusal surface from the distal aspect than we would from the mesial. And you see that tiny little distal cusp here. That's a D. Oh. And here you also, they show you that the distal root is more narrow than the mesial root as well. And you can see here, you see this distal root and you see the mesial root outlining it here. And there is no depression on the distal root characteristically, meaning, you know, there's always can be one, but that's not the answer to the question, okay? This tooth is typified by a deep mesial depression on the mesial root. The distals tend to be flat. Which makes them easier to treat. Okay, here are the 5 cusps, again, labeled on an occlusal image of the crown: mesiobuccal, distobuccal, distal, distolingual, and mesiolingual. And then the marginal ridges are shown here in green. You see the one on the mesial here is longer than the distal, which has been typical of all of the teeth. Okay. And then here are the grooves. All right, there is a central groove here in blue. The mesiobuccal groove going between the 2 largest cusps of the buccal aspect is the mesiobuccal groove in red, distobuccal in black, and lingual groove in green. So you need to know these grooves, okay? You will be tested on them and naming them. Just remember, you know, if there's 2 of something on a buccal surface, one has to be mesial and one has to be distal. So if that'll help you with like mesiobuccal, distobuccal, and then the extra is distal. It gets, the distal is the smallest. Okay, so that's a pretty basic groove pattern. It also has the triangular grooves, but we're not going through the naming process on this tooth. You just need to know that they would be grooves adjacent to the triangular ridges. Let's see, this one here, here's one, probably here's one, here's one. Okay, so the triangular grooves are adjacent to the triangular ridges of the tooth, but we're not going to go and draw and name all of those. Just the main grooves. Okay. There's also fossas and pits. All right, there's a mesial, a central, and a distal pit. And then these triangular fossa on the mesial and distal aspect, and then a large central fossa here in the middle of the tooth. So sometimes the doctor comes over and they ask me what did I find, and I'll say, well, there may be some decay in that distal pit or on the occlusal of number 30, and they check. I watch. They check the central pit and the mesial, but they don't check the distal. It's the distal pit. It's in the distal pit. So we do need to know the names of the pits, because sometimes you just have to specify the names of the grooves as well, because sometimes things occur, you know, in a groove. You know, I found decay like on a patient. The doctor checked the patient. It was the last patient of the night, and then he left. And then I just checked around the patient and then, again, and then I found something suspicious here in the lingual groove that he hadn't mentioned. So when the patient came back in the next week, you know, I had it all written down specifically in the lingual groove of the occlusal surface of that tooth. Please check that area for decay. So clinical implications of the first mandibular molar. We're going to talk about this a little bit separately. It tends to be the first tooth to erupt in the entire dentition, sometimes even before the lower central incisors. It's used to classify occlusion with the maxillary first molar. If a first molar is lost, the second molar is going to lean right on in. And you see here that this is actually a second molar here. It's not a first. That has leaned into the space that was left by the first. And it happened so long enough ago, you know, it actually produced a contact here. You have to check the pits for caries. Longitudinal grooves on the roots can be difficult to instrument. You got to look for furcation involvement on the buccal and lingual aspects in patients with periodontal or gum disease, and evaluate cusp tips for wear. But here's just a really cool x-ray. You can just see that the first molar tooth has been gone so long that these other two teeth are just leaning right in. The first molar teeth are, you know, important to keep, and because children get them so young, they often end up with enormous fillings like this on them, you know, here and here, just, you know, massive fillings and root canals. Ultimately, root canal treatment. Okay, second molars. There is no distal cusp on the second mandibular molar. It's only on the first. So here, mesiobuccal, MB, and here is mesiobuccal. Here is distobuccal. Here is distobuccal. And then the distal. The distal cusp is not present on the second molar. It will have a buccal groove on the second as it does on the first. So you see a little one here. So the little buccal groove circled. The root trunk can be even shorter, and the roots, again, not as widespread. So just like on the same situation as on the first maxillary molar compared to the second. So it's a smaller tooth than the first is.
So wait, in the maxillary, is the second molar usually larger, but in the mandibular, is the second molar smaller?
No, in the maxillary, second molar is smaller too.
Oh, is it? Okay.
Yeah. Oh yeah, the molars are like that. First molars are largest, seconds are second largest, and thirds are third. No, yeah, are the smallest. Here you see, you know, the less divergence of the roots of the second compared to those of the first. They're quite close together. And here is the first. On the lingual aspect, two cusps, mesiolingual and distolingual, just like the buccal. And again, those cusps are going to be taller and sharper than their buccal cusps are. So this is a repetition of, you know, the first molar actually too. Distal's more rounded and shorter than the mesial. And there is a lingual groove shown here in blue. Okay. Heights of contour. Again, that buccal cervical ridge is shown here with the orange star, and the lingual height of contour is in the middle third. So the buccal cervical ridge forms the height of contour on the face, on the buccal. All posterior teeth have a lingual height of contour in the middle third. And the mesial surface, again, is going to be wider buccolingually than the distal is, and taller. So let me find my cursor here. I lost it. Let me where it's somewhere. Here we go. So it's taller and it's wider than the distal. All right. Distal surface is shorter than the mesial. We've mentioned that already. Okay. And the distal root is smaller than the mesial. So that's the same as before. Oop. The distal root is, I can't draw on this paper's moving. Let's try dust on my desk. The distal root is smaller than the mesial. So comparing the first and the second here, different in number of cusps. The first has 5, the second has 4. Okay, you see there's a simpler groove pattern on the second. Okay, it has a crisscross groove pattern. A buccal and lingual going this way and a central groove going across the middle aspect of the tooth from mesial to distal pit. So the second molar tends to have this cross-shaped groove pattern. The first does not because it has that distobuccal groove here. But it does have the same pits as the first does, central and a mesial and distal. Mesial distal pits. Okay. This is just a patient image of the two molars. Where's my cursor? Oh, there it is. So here, you see the 3 buccal cusps on this tooth. 1, 2, and 3. And there's only 2 on the buccal of this tooth. This is a filling here in the buccal pit on this tooth. You can see here very nicely. That's the buccal pit filling. Okay, third molars, many variations in size and shape, just like the maxillary thirds. And typically it has 4 cusps like a second does, but it varies a great deal, but this varies. I'm not going to ask that question, but lots of variability. These crowns are going to taper distally. So, if you look at them from this view, the distal aspect in blue, it's not as clear on this one, but is shorter than the mesial aspect. So if I do that in green, the mesial aspect is wider so that this tooth tapers distally. And that's what I mean by that. It also does that from the buccal and lingual aspect. It gets shorter on the distal, so the crown leans distally. Wrinkled groove patterns, all created by these numerous accessory roots, additional roots, in addition to the main roots. Grooves, due to the wrinkled groove patterns due to accessory grooves. And that's all these little extra grooves here that can do this, okay? Cause it to look a little bit wrinkled. The roots are shorter and often fused, so same as the maxillary thirds. So first, second, and third, buccal comparison. Okay, first is largest, second is next, and then the third is the smallest. And we can even see that in real life on our patients. First, second, and here's the fused roots on a third. It won't always be that way. If they don't have fused roots, a lot of times they're very thin, very, they'll bend and twist, and very unusual in shape. They don't have this nice bulk of a main root like the first molar and second molar will have.
Are they taller?
Are they duller? You mean blunter?
Taller.
Oh, taller. This
Taller.
tooth here? No, they're
Okay.
not taller. The third
Okay.
molar is not taller. Is that what you mean?
Yes.
No.
I mean the root, if it's taller than
No, the root's going to be shorter than
shorter.
this. Well, this
Okay.
one is down here, actually.
Mm-hmm.
No, this root will be shorter.
Okay. Thank you.
Yeah. And this distal is here. Here's a variation called a mulberry molar. And these are mulberries. So it's just a molar that has all these extra cusps on it, that it looks like a, you know, a berry. So this is a mulberry molar. So some clinical implications of third molars. The mandibular thirds are those the third molars that are most likely to be impacted. And as you can see, this one is leaning and growing right directly into the distal root of the second molar. And that's a problem. That tooth needs to come out. It also has roots there's a mandibular canal that runs along the entire length of the mandible. And in this canal is a nerve that supplies all of the teeth on that side of the jaw and the lower lip. And so if the roots of the mandibular third grow to a length where they are wrapped around this canal or involving this canal and then the tooth is extracted, it can actually traumatize or even tear this nerve enough that a patient can lose sensation to that teeth on that side of the jaw or the lip. So if any of you had wisdom teeth extracted, you signed a waiver that you understood that because of those extractions, you may have numbness in the jaw. That may be permanent, and in some cases that is the case. I haven't seen a lot of that myself. Doctors are very, very careful and very good at what they do, so it's not a problem. But, you know, lucky people, they're congenitally missing. Third molars can be missing, just as there can be extra molars or fourth molars. They can also be congenitally missing. So. Okay, any questions about that one? This is a mesial drift of a third molar that where the first and second were extracted. And you can see it's almost like lying down here. Here's the bone and that crown is just like leaning over. So when teeth are lost, when back teeth are lost, it has implications. You know, the dimensions of the bite and everything change, and it can have implications for first teeth in the front as well. When one tooth is leaning into the CEJ of another like this, that's a cavity there. It's not if it's going to happen, it's when it's going to happen. There will be decay there. Look for it and watch for it. I think a lot of times dentists are looking at the crowns of teeth, and they're looking for decay in these areas and proximal and the crowns. And I feel like hygienists working on roots, we see it at the CEJ more commonly. And there's a cross section, another cross section of a mandibular third or a mandibular molar. It's kind of a box. So these tooth I mean, and that's a much less complicated thing to structure to instrument is what you can see here. You can also see the mesial is broader or wider than the distal here, quite distinctly. So this is near the CEJ region of the tooth. It's not gotten down, didn't break off down lower in the roots when a patient with gum disease. So the lower molars, again, you got to look for severe wear on them. You can see these cusps are quite flattened out. Patients who are doing this to their teeth can not only cause this wear, but they can actually cause fractures in the teeth that result in their loss. They have to be removed if it goes down onto the root, into the root. Okay, occlusion. So here we go with Engel's classification of occlusion. We've talked about the molars, first molars and everything. So we got to talk about how to assess occlusion, because you're going to be doing this on every patient you see in our clinic. And it will be on your board exams. There's no reason to miss these questions on the boards. All right, so I think I got this out of Wilkins, your textbook Wilkins. So again, the landmark, the stationary landmark is the mesiobuccal cusp of the maxillary first molar. And it should line up with the buccal groove or mesiobuccal groove of the lower first molar. They call it the buccal groove here. That is a class 1 occlusion. That's ideal. And when we have the first molars present, we don't look at the canines, okay? We don't look at them. They're here showing you, but we don't look at the canines if the first molars are present. Okay. It is called a neutroocclusion. There's another term for that class 1 occlusion. Now, sometimes we have our molars in ideal position, but there's other teeth that are in malocclusion. There may be a crossbite in the anterior, or just twisting and torso versions of anterior teeth that are common, but the molars are fine. So that would be a class 1 malocclusion or class 1 neutroocclusion. Typically, it's called a class 1 malocclusion. Okay, so we can have a perfect dentition, like the person who comes out of the orthodontist office with the completion of orthodontic therapy. Everything's perfect. And that's a class 1 normal, ideal occlusion. There can be some patients who then don't wear their retainers well, and those lower anteriors start to slide back into their twists and turns. And now you have a class 1 malocclusion because those teeth are not in an ideal position. There is a class 2 occlusion that we'll see here next in your molars. Okay, and here is, let me do the red first with your maxillary landmark. That's the tip of the mesiobuccal cusp. All right, and then the buccal groove of the mandibular molar is distal to it, right? It is distal to its ideal position. So it's a distocclusion, and you know that means it's a class 2 from your canines. Now, this can be of 2 divisions. you can have here, I'm going to underline class 2 distocclusion again in the next image. Let me find my cursor. Here it is. You can have a division 1, class 2 division 1, or a class 2 division 2. So a division 1 has maxillary anterior teeth that are protruded, and mandibular teeth are a bit retruded. So you have this giant overjet.
Wait, what does that mean?
It's a giant overjet here, right?
Protruded? What does that mean?
Oh, back in position.
Oh, okay, gotcha. That makes sense.
Protruded is out forward in position. Retruded, like retreat, is back.
Got it.
And if the army retreats, they're going back. Here is a division 2. This is class 2 division 2. Class 2 is the only one that has 2 different types or divisions. And in a class 2 division 2, usually it's the central incisors that are retruded. Okay, they're leaning back into the mouth. And one or more anterior teeth are protruded. So usually it's the ladders will be sticking out this way. So here it says mandible is retruded. So again, the mandibular and region is too far back. And one or more maxillary incisors are retruded. And usually it's the centrals that are back in position, as the blue arrow is showing. And I'll show you a picture of that. So you need to know your divisions in a class 2, okay? And then the final classification is a good old 3. And there's only one type of that. It's either a 3. It's a 3. 3 or a tendency to a 3. There can be tendencies here. Let me draw in the line here on this one. So again, I look at the mandibular tooth and I see that my landmark is anterior or mesial to my maxillary molar landmark. And again, it has to be a full cusp width off to be a full 2 or a full 3. It says the width of a premolar, but that's a cusp, because they have one buccal cusp. Okay. You're going to have to study this. So here we have a class 1 occlusion. Pink is the maxillary landmark and green is the mandibular landmark. Class 1 molar occlusion. And the teeth are lined up beautifully. These incisal edges all line up together along with the buccal cusps in the posterior. It is a perfect alignment, a smooth arch form. That's a class 1 normal occlusion. We just call it a class 1. The profile is called mesognathic, okay? So a line drawn down the front of the face here is is such that the chin is generally in pretty good alignment with the forehead prominence here. Okay. There can be a class 1 molar relationship, as I said before, but other teeth are malaligned. Okay, so here is a class 1 malocclusion. Molars are an ideal relationship, but there's individual teeth here that are, this one's in torso version, this one's in a bucco version. Okay, so they're malaligned. It's a class 1, but with a malocclusion. Midline's off also a little bit here. You see the midline of the mandibular is not quite in alignment with the centrals, the maxillary.
For the midline deviations, how do you classify them? Is it by like which way the mandibular is off?
Yeah, it's by how many millimeters.
So would this be off to the right?
This is to the patient's right.
Okay.
It's always to the patient's right. When we note conditions or anything, it's the patient's right. So it's backwards for us. This is a rather grainy picture, but this is a class 2 molar relationship, okay? Here's the cusp tip of the maxillary molar. And here is that buccal groove on the mandibular molar. It is so far off, it looks right, doesn't it? Because that tip's kind of leaning right into that crevice, like the cork in the bottle kind of thing. So, but that is a disto-occlusion because the mandibular molar is distal to its normal position. And I say that like that over and over again so that you guys think that way. It's easier to look and say the maxillary tooth is mesial too, but it's not that way. It's a disto-occlusion. The mandible is distal too. Here is a class 2 division 1 malocclusion. This is a model. You see the giant overjet. And you see, here's the buccal cusp here, and the buccal groove is back here. And you see these buck anterior teeth on the image here. This is a baby molar here. This is not a permanent molar right here. Okay, so I'll put a little Roman numeral 1. It's a primary tooth and a degree sign. Here is a type of class 2 division 2. So again, you see the maxillary centrals are retruded and the laterals are sticking out. But the molar is in a class 2. I'm not showing you that here, but that's the position. And in a class 2 malocclusion, the patient may have a retruded, kind of retrognathic profile. So you see this mandible is way posterior to, here we go, that forehead region here. So you see that small, more retruded type of mandible. So if your patient walks back and you just kind of catch a glimpse of the profile and you see that the mandible looks small, you know, you might expect a class 2 malocclusion in that patient. Okay. I put a little tooth here because this is a perfect class 3 malocclusion case, but I don't have a molar for him, molar, so I don't have a lot of these a good class 3 occlusion picture. So again, if I look at the maxillary cusp, there it is, and then my mandibular groove, and it is way mesial to that cusp. So this patient has a mesio occlusion, and it is a class 3. So again, angles is very limited to how it looks at occlusion. Orthodontists are not only going to look at teeth, they're going to look at the size of the bones of the jaws, because that's a factor here too, oftentimes. But as hygienists, we're just going to look at the teeth and classify them, because they're indications that a patient needs a referral to an orthodontist. Typically, then you'll have the underbite or crossbite in the anterior like this. And a class 3. Okay, and here's Angelina Jolie. She probably had was probably born with that, she has that prognathic profile. The chin's forward, and she may have had a class 3 occlusion before orthodontics. Who knows? But you expect that prominent chin. It's called prognathic profile, protrusion of the mandible. Just to make you crazy, there can be tendencies in these malocclusions, just like there are with the canines. So here, your mesiobuccal cusp of your maxillary molar is in red, buccal groove in green, and you see it's just a little bit too far forward. So it's a class 1 tending toward a 3. It's not a full cusp different. That's a little short arrow we got there. Okay, remember, that's a full cusp. That's a full cusp. That's a full cusp. It's a big difference for a full 2 or 3. Again, here, oops, didn't hit the right slide. Didn't come forward. So here again, here is my buccal groove on the mandible, and I see my mesiobuccal cusp of the maxillary molar here. So again, class 1 tending to a 3. Because this is mesial to my maxillary landmark. Other types of malposition. So 1 and 2 is in the anterior posterior dimension. It says, is the mandible or mandibular teeth too far mesial to or anterior or posterior to or distal? But there can be things that are off in the lateral dimension also, from side to side. So we talked about in end-to-end or edge-to-edge malocclusions in anterior teeth, right? Edge to edge. I'll just write edge/edge, okay? In posteriors, it's called end to end. Same thing, but it's end to end. When it's cusp tip to cusp tip in the posterior region, you have an end to end occlusion. I think incisal edge. That helps me remember that molars are end to end in that regard. So this is a lateral malposition because the maxillary teeth should be more this direction so that they overlap the buccal cusps of the bottom teeth. Here is a posterior crossbite. That buccal cusp of the mandibular premolar is buccal to the cusp of the maxillary premolar in canine here. So that is a posterior crossbite of number 28 with, number 5 and 6. So this is 28, and that's how you would do it. Oh, let me find my cursor. Where is it? Oh, here it is. 28 with 5 and 6. Here's one that's just the most amazing malocclusion ever. You see an end to end here. I'll put an E to E arrow. This is a crossbite, put an X. Here is a crossbite, another X, another crossbite here, crossbite here. This one's in crossbite with this tooth, but it's edge to edge here. Pretty cool, huh? And now edge to edge here. And then these are normal. Getting a bit of an overbite here, but this patient just it's a very fluid transition here, as it goes from edge to edge to normal. No, crossbite, I'm sorry, crossbite, silly me. Ugh. And then, no, it goes from end to end. Let me put this back here. See how easy it is to do it? So no end to end versus edge to edge. Incisal edges touch one another. That's edge to edge. So that's just a sample of what what you can see in the human dentition. I would expect you to be able to tell me, if I ask for specific teeth, which ones are end to end. Name the position of tooth number. I would give you a better picture of the posterior back here, but the incisors here, I'd say which teeth, or name the what is the malocclusion of number 9 with 23 and 24. Yep. You should be able to do that. Okay. What is the malocclusion of 8 with 25? It's a crossbite. Okay. And here is another patient. Here is a crossbite. You see the buccal cusps of the mandibular teeth are buccal to the maxillary teeth. Here he's got end to end. So these teeth are in crossbite here. Here's a crossbite. So you just see what can happen in a dentition. And there's a super overbite in the posterior. Even the lingual cusps, oh, wait a minute, you don't see it. Even the lingual cusps are buccal to the mandibular teeth. It's just a giant, it's a type of crossbite that's very unusual. But I just thought I'd show you that too. It's a possibility. Okay, so let's take a 10-minute break. I'll see you back at